anatomy. In head and neck, 70–80% of the battle is won. So anatomy is the key, and that is why this course is going to emphasize on anatomy. So today we are going to cover base of skull, which includes the cranial nerves, because cranial nerves pass through the base of skull. And this is what we are going to cover today. This is more or less paranasal sinus territory, but I have included this today because the cranial, there is a sort of a connection with the base of skull, pterygopalatine fossa. And then orbital anatomy is relatively simple. But having said that, the connections with the base of skull, we will emphasize that. So it's going to be a lot of repetition, repeat. You will become sick and tired. But the idea of repetition is that when you go home today at 9 o'clock, you will think that now you know something. And tomorrow, when you go to your departments, please go through this open a few CT scans and go through them when it is fresh in your mind. Acknowledgements, my favorite, teaching resources, StatDX, Netter Atlas, these are all-time favorite. Having said that, in head and neck, my favorite is Hans Berger and his books. So I'm a huge fan, and some of these handbooks, I told you last time how precious they are. But having said that, so these are my acknowledgements of the resources which I'll use. Just a quick overview, and I'm going to rush through this in 5–7 minutes because we are going to actually cover this in the next sessions. But having said that, what is the global view of head and neck? Head and neck can be divided into various portions. Temporal bone, which is the most difficult part of the head and neck anatomy, we covered it last time. Today we are going to cover base of skull, including cranial nerves. So this is base of skull. And then we will cover orbit. Then next time, we will go into paranasal sinuses, sinonasal, but pterygopalatine fossa we are going to cover today. And then comes, this is oral cavity, this is hyoid bone. So head and neck is divided into suprahyoid head and neck and infrahyoid neck, which includes larynx. And last time I introduced this concept to you that the deep cervical fascia has got multiple layers, and due to that, we can divide head and neck, or neck particularly, into various spaces. And these concepts, we are going to sort of revisit them next session onwards. In suprahyoid neck, these are the spaces: pharyngeal mucosal space, parapharyngeal space, masticator space, parotid space, carotid space, retropharyngeal space, perivertebral space. So we are not going to waste our time today on them because we are going to learn the details in the subsequent sessions. Infrahyoid, so this is hyoid and this is the infrahyoid neck, is divided into visceral space, carotid space, retropharyngeal space, perivertebral space, and posterior cervical space. Key point to remember is that look at these three spaces in yellow. These actually they are in the infrahyoid neck, and they go or traverse the suprahyoid neck also. So they act like tubes. So these concepts are, we will revisit them. Now, key point, and this is a key point for today's talk also, that you have to remember that the spaces, some of them, they go all the way up, and they are in contact with the base of skull. So this purple space is masticator space, and masticator space is this space. If you see, this is mandible here, and around the mandible there are muscles of mastication. So this space goes all the way up and touches the base of skull. There is a foramen here, which is known as foramen ovale, and today it is part of our curriculum. And what can happen is that a pathology is sitting in the masticator space, and it can go through these connections into the intracranial cavity. If it is a tumor, it can spread upward, and these are the type of cases they show in the exam. It can go up into the intracranial cavity. We call it perineural spread of a tumor. Infections can go up, and you can see that if there is a bad dental abscess, that infection can travel all the way here and enter inside, and then it can cause epidural empyemas, etc. So last time we did cover another space, which is this space. This is the parotid space. And we did learn last time that the parotid gland is here. This is the stylomastoid foramen through which the facial nerve comes. And a tumor sitting in the parotid gland can go upstairs into the temporal bone through this. Then this is a space, we covered it last time, partly. This is the carotid space. And the carotid space is here. It is touching the base of skull at the jugular foramen. And this is the carotid canal. And we did cover tumors like schwannoma or glomus jugulare, etc. So these concepts are critical, and we will revisit them as we proceed. Now, the key concept in head and neck radiology is that what is the epicenter of the lesion? So you have to think like this. What is the epicenter? From where the lesion is arising? In the neck, for example, is it what we call is it a particular space? Is it a particular location? And then you can go to the differential diagnosis. So you have to learn the differential diagnosis. And the final diagnosis will be based on radiological features and the clinical history. So these concepts are extremely important, and many of the times you will be able to actually give one particular diagnosis. So, and last time also I encouraged you, let me stop these annotations just 1 second. Now, that in the current Chapman, we have written a new chapter, which is the head and neck chapter, and we have completely revised it according to the spaces. So I encourage you to follow this, and we will show it to you as we go through this course also. So, for example, this is a masticator space mass. This is masticator space. If you see here, this is the mandible. These are muscles of mastication. On this side, there is a mass. And this is, by the way, a chondrosarcoma. Having said that, if you tackle this in your day-to-day radiology or your exam, the key thing, first of all, see the radiological features, go through the differential diagnosis. So this is the masticator space lesions. And there are, all of these differential diagnoses, and from here you can pick up, specific diagnosis. So we will revisit this. So this was sort of an repetition of what we covered or we highlighted last time also. And now we go into skull base. Right. So last time, candidate 1, can you confirm that this slide, parts of temporal bone, is visible to you?
Yes, it is.
Okay. Last time we covered the temporal bone. The temporal bone is the bone which is in red here. And this bone, temporal bone, has got, technically speaking, 5 parts. You don't have to remember, but just to make it more, specific. Now here you have got this is the tympanic portion of the temporal bone, where part of the external auditory meatus is. Now this is the styloid process. This is the mastoid part of temporal bone, and this is the squamous part of the temporal bone. Now our interest is in this part. This is the petrous part of the temporal bone, the densest bone in the human body. And this thing is, if you see the global picture of this, this is, here it is joined with the occipital bone and also with the sphenoid bone. So there is a synchondrosis here, basi-sphenoid synchondrosis. There is a fissure here, which is the petro-occipital fissure. Now, the petrous temporal bone has got various foramen. Last time we covered them in detail, but the key one is this one, internal auditory meatus, or internal auditory canal. Then there is carotid canal, which is inside it, and there is the facial nerve canal, eustachian tube, etc., etc. So we have covered this. Today, our aim is to cover whole of the base of skull. Now, this is the base of skull, and base of skull is made up of 5 bones. 3 of them are midline, and these midline bones are single bones: ethmoid bone, sphenoid bone, occipital bone. And then there are paired bones: frontal bone and temporal bone. So before we proceed further, just give me a moment, please. So as this is the midline sagittal view, and the pituitary fossa, this is the pituitary fossa, and pituitary fossa is made up of the sphenoid bone. But this bone here is the clivus. Key point to remember is that part of the clivus is made up of the sphenoid bone, and part of it is made up of the occipital bone. So as the child is growing, there is a line here, which is because of the joint. There is a synchondrosis here, and as the person becomes an adult, this fills up. And this is known as spheno-occipital synchondrosis. So beware of this, and in a child, don't think that this is a fracture here, particularly in a case of trauma. And this is the appearance on an MR. One key thing to remember on this MR is that the clivus has got a lot of marrow, and this marrow is what we call fatty marrow. So that is why it is high signal on this T1 weighted sequence. So beware of this, because this is an exam appearance. They will show you cases in which this high signal of the clivus is lost, and that means marrow infiltration. So you have to remember that. Now, coming back, this is the sella. This is the what we call sella tertica. This is dorsum sella. This is the posterior clinoid process, and this is the tuberculum celli.
please remember that the sphenoid sinus, this is the sphenoid sinus. It is totally made up of the sphenoid bone. This is the anterior clinoid process. Point to remember that the anterior clinoid process is different origin within the sphenoid bone, which I'm going to just tell you in the next slide. Now, this is the sphenoid bone. Sphenoid bone is a very complex bone. Key parts, this portion here, the midline portion, is known as basisphenoid. Then there is a lesser wing. So this is a lesser wing of sphenoid. This is the middle cranial fossa, and the lesser wing is medial, and it also produces the anterior wall of the middle cranial fossa. This thing here is the greater wing of sphenoid. So this is the basisphenoid, this is the lesser wing, and this is the greater wing of sphenoid. Now, basisphenoid we have already covered, and the sagittal is the best view to explain this. All of this is basisphenoid. However, this is the anterior clinoid process. Anterior clinoid process is a part of lesser wing of sphenoid. And key point to remember is that just medial to this anterior clinoid process is the optic foramen. So this is the optic foramen from where the optic nerve is coming from the orbit. So once again, on this sagittal view, the posterior clinoid process is part of the basisphenoid. The anterior clinoid process is part of the lesser wing of sphenoid. Now, this is the greater wing of sphenoid, and you can see a few foramen. This foramen is extremely important. This is the foramen ovale, and here is what we call the V3, which is mandibular division of trigeminal nerve. It passes into the neck through this. This is foramen spinosum, and foramen spinosum is from where the middle meningeal artery passes. So if you see, sphenoid bone actually is more complex than this, because part of it extends inferiorly, into the deep facial skeleton. And one of the things which is important for our today's curriculum is the pterygoid process. This is the pterygoid process, and this is the lateral, and this is the medial pterygoid process. When we are going to learn the pterygopalatine fossa, then this will these terminologies will come back. If you see, this is a view other way around. We are looking at the skull from the top, and this is from the bottom, and this is foramen ovale, and this is foramen spinosum. So this is the sphenoid bone. Now, other than foramen ovale and foramen spinosum, there is another foramen here. This is known as foramen rotundum, and this will be better visible on a coronal CT scan, not an axial. Now, here is a fissure. This fissure, if you see here, this is the optic foramen, and which will be here will be the optic canal. So this is lateral to that, and this is the superior orbital fissure. So superior orbital fissure, where few structures go. For example, the third nerve, the fourth nerve, the V1, which is the ophthalmic division, and also the superior ophthalmic vein. So once again, this is optic foramen, this is superior orbital fissure, this is foramen rotundum, this is foramen spinosum, foramen ovale, and this small one is foramen spinosum. Now, this thing here is foramen lacerum. Key point to remember is that in a live person, in an alive human being, this foramen is filled up with fibrocartilage. There are some small nerves and vessels going, but on a CT scan you can see it as a defect in the between the bones. As far as we are concerned, radiologically speaking, nothing important passes through this foramen. The carotid artery, which is passing through the carotid canal, we have covered it last time, passes superior to the foramen lacerum. So it passes superior. And that is why this portion, which passes superior to the foramen lacerum, is known as the pre-cavernous or the lacerum part of the internal carotid artery. Now, if you stretch your imagination, this is the pituitary fossa. So the pituitary gland is sitting here. From here to here is the cavernous sinus. So you can imagine that the internal carotid artery will come here, then go here. It passes through the cavernous sinus. You can also imagine that some of the cranial nerves which are sitting in the cranial, in the cavernous sinus, which is here, then they pass through the superior orbital fissure and the foramen rotundum, etc. So coming back, so this was the sphenoid bone. Anteriorly, this is the ethmoid bone. Ethmoid bone, at the base of skull, there are other structures of ethmoid bone which we are going to learn in detail in the next session. But for today's session, if you see, this is known as cribriform plate of ethmoid bone, because nerve roots, they pass. This is the olfactory nerve, the V1, the cranial number 1. And they ultimately form the olfactory nerve. Olfactory nerve is not seen in our regular, MRI scans, but you should know that they, anatomy-wise, this is what we call the olfactory group. This portion here, which is well seen here, is known as crista galli. Crista galli should be embedded in your mind because on MR, you see it very well. And this is a bone where the falx, actually it is attached. And this thing also has got fat. So it will be fatty signal for you. So anterior cranial fossa in the midline is made up of ethmoid bone. And this is the cribriform plate, and this is the crista galli. Then comes the sphenoid bone. And sphenoid bone has lesser wing, greater wing, and the basisphenoid, as we have covered. The basisphenoid joins the occipital bone to form the clivus. Here it forms, there is a synchondrosis with the petrous apex, which is known as basisphenoid synchondrosis. Another terminology which should be in your mind is that if this is the lesser wing of sphenoid, and the other side, which is not shown on this diagram, will be on the other side. The bone in the middle is known as planum sphenoidale. So in the midline, this is planum sphenoidale. Why is it relevant for vocabulary wise? You should know this because there will be meningiomas which are sitting here. And you will tell the examiner that this is a planum sphenoidale meningioma. And this will be, if a meningioma is sitting here, you will say that this is an olfactory groove meningioma. So these terms are important. Similarly, there can be trauma cases in which, a fracture line will be going like this. And the examiner will expect you to say that this is planum sphenoidale fracture. So now coming back, so this was ethmoid, this is sphenoid, this is occipital bone. So occipital bone has got 3 parts. This is the basi-occipit. Remember, this was the basi-sphenoid, so this is the basi-occipit. Basi-occipit is the part of occipital bone which helps to form the clivus. Other than that, there is another part here which is known as jugular tubercle, and we will see it on a CT scan, particularly on a coronal, very well. And this is where the 12th nerve goes out, the hypoglossal canal, which is not shown here very well and not shown very well here. Now, the second part of the occipital bone is the condyles. And all of you know the condyles. They are very easy to remember because this is where the joint between the atlas and the occipital bone is. That, you know, the atlanto-occipital joint. So the first part is basi-sphenoid, which includes the clivus as well as jugular tubercle. Second part is occipital condyle, which is not visible on this diagram, but that's common sense. That is where the atlanto-occipital joint forms. This portion, all of this is known as the squamous part. Remember, this was the squamous part of the temporal. So this is the squamous part of the occipital bone. And the foramen magnum is sitting there. The key thing, which I told you last time, is this foramen. And this foramen is favorite, you know, for your exam also. And this is the jugular foramen. And one anatomy question is that jugular foramen, where, in which bone it is? So it is not in any single bone. It is in between the temporal and the occipital bone. The jugular foramen has got two parts. You don't have to remember, but radiologically speaking, actually, you will see this kind of structure. So you should not be confused. This part is known as pars nervosa. This part is known as pars vascularis. In the pars vascularis, on a CT scan, it will be rounded, by the way. Now, the jugular vein passes through it. And here in pars nervosa, the 9th nerve passes through it. And then the 10th nerve and 11th nerve passes through this pars vascularis. Keep it simple. Through the jugular foramen, 3 nerves pass, 9, 10, and 11, along with the internal jugular vein. The 12th nerve passes through the hypoglossal canal, which is not very well seen, and is anterior and medial to the jugular foramen. Now, coming back to the cranial nerves, this is the cranial nerve 1, olfactory nerve. So you can see how it goes into through the cribriform plate. Radiologically speaking, we cannot see it, right? Number 2, the second nerve is the optic nerve. So the optic nerve passes through the optic foramen. Third nerve, which is cranial nerve 3, oculomotor, trochlear, and 6th nerve. All of them, they supply the muscles of the orbit. So they pass through the superior orbital fissure. Now, 5th nerve, what happens with the 5th nerve? Trigeminal nerve. Trigeminal nerve, here is a structure which is not seen on this diagram, but somewhere here, which I will show you shortly, is Meckel's cave, where the trigeminal nerve divides into ophthalmic, maxillary, and mandibular division. So the ophthalmic passes through the superior orbital fissure, which is V1. V2, which is the maxillary, passes through the foramen rotundum. And V3, which is the mandibular, passes through the foramen ovale. So let me repeat the first 5 nerves. This is the V1, which passes through the ethmoid, and we don't see it on radiology. Sorry, not V1, cranial nerve 1. Cranial nerve 2, optic, passes through the optic foramen. 3rd, 4th, 6th passes through the superior orbital fissure into the orbit. V1 also passes through the superior orbital fissure. V2 through the foramen rotunda. V3 through the foramen ovale. Now, sixth nerve. Now, sixth nerve passes, somewhere here. It is a thin nerve. It passes through. This is the sphenoid, sphenoid. So it passes through it through a canal, and then it goes into. I'll come back to this point, but here I've told you that it exits the base of skull through, the superior orbital fissure. But another thing which we have to learn is that it passes through a canal here in the sphenoid bone and then goes into the cavernous sinus and then goes here. So we'll come back to this. Now, coming back to the seventh and eighth nerve, we know that seventh and eighth nerve, they go into the IAM, internal auditory meatus. Last time we covered it. Now, ninth, 10th, and 11th, they pass through the jugular foramen, and the 12th nerve passes through the hypoglossal canal. So this is what it is. And this is foramen ovale. And you can see that here, the V3 will pass, stylomastoid foramen, 7th nerve will pass. This is the jugular foramen, where the 9th, 10th, and 11th will pass. Candidate 1, are you with me?
Yes, Dr. Khan.
Okay, name this foramen where I am pointing out.
Okay, that's foramen. The top one is lacerum, so this one is foramen jugular. Sorry.
Can you see my mouse? Can you see my mouse?
Yes, I can. Yes.
Okay, so say again now. This one where my mouse. I'm moving my mouse. You said
below the jugular foramen is this one.
Excellent, excellent, well done. And what is this?
So this one is the internal auditory canal, internal auditory meatus.
Excellent. This one.
Ovale, foramen ovale, foramen spinosum.
This one.
This is the optic canal.
Just 1 second.
No, rotundum.
What is this?
That's the optic canal.
Yeah, so this is the anterior crinoid process, and this will be medial to that. On a CT, you will see it like that. And this foramen?
Lacerum.
Lacerum, and which is not a true foramen in real life. Good, well done. So, of course, from your books, you can, see these tables. There will always be two perspectives to see the same thing. First of all, learn the names, the V1 till V12, the cranial nerve 1 till cranial nerve 12, and what are the names and passes through what. This is one perspective. And the second perspective is, so this is the 12th nerve, and the second perspective is that learn from the perspective of the foramen, that what structures pass through each foramen. Some of these things are important for anatomy students because they ask in the exam, but many of them are not important for radiology because we cannot see them, small branches and things like that. So the big things you have to remember, and I'll just concentrate on big things. So the both perspectives you should remember, the perspective of the foramen and the perspective of the nerve. So a recap here. This is the cranial nerve 1, olfactory bulb and tract. As I've told you, difficult to see on 1.5 Tesla MR. Then number 2, which is the optic nerve. Then number 3, which is, so 3 and 4 point to remember for radiology because on MR we can see it. Please remember that 3rd and 4th, they come out at the level of midbrain. Remember that. So 3rd and 4th are at the level of midbrain. And then we will go more inferiorly. So this is the third nerve. The trochlear nerve, it arises from the posterior portion and goes through the ambient cistern and then comes anteriorly. Then comes the fifth nerve where the action is. Look at this, how chunky it is. And there is a ganglion here, which is the Gazerian ganglion. And here it divides into three parts: V1, V2, and V3. And and as we have learned that they go into different foramen. Then look at this. This is at the junction of pons and the medulla, and this is the sixth nerve. And so it will also go ultimately out of the skull through the superior orbital fissure. And now these are the nerves which are arising from the medulla. And these are, correction, I missed the seventh and eighth nerve. So seventh and eighth nerve are arising. So this is the facial nerve and this is the vestibulocochlear. Both of them are arising from the pons, and they will go into the IAM. And then 9, 10, 11, and 12 from the medulla. 9, 10, 11 will go out into the jugular foramen, 12 through the hypoglossal canal. So these are the nerves. Now, repetition of the foramen. So this is the olfactory, this is the optic. Look here, superior orbital fissure. And third nerve, fourth nerve, sixth nerve, and V1. Then this is the rotundum, which passes through, the V2 passes through it. This is ovale, and V3 passes through that. Here is 7th and 8th, then 9th, 10th, 11th through the jugular foramen, and this one is the 12th nerve which passes through the hypoglossal canal. And now, please concentrate on the cavernous sinus. So it is very important part of anatomy, and in the cavernous sinus, the internal carotid artery passes through it also, which is not shown on this diagram, but there are few nerves which pass through the cavernous sinus, and which include all of the nerve which pass through the superior orbital fissure as well as the V2. So these are the nerves which pass through it. Look at the sixth nerve, because sixth nerve will go into the sphenoid bone here, and then go into the cavernous sinus, and then go into the superior orbital fissure. The third nerve, the fourth nerve, the sixth nerve, all of them, they go into the cavernous sinus. Similarly, this is the fifth nerve, and the V1 and V2 will go into the cavernous sinus. V1 will continue into the superior orbital fissure. V2 will go out through the foramen rotundum, but the V3 will not go into the cavernous sinus. This is very important. When we covered CNS, I gave a lot of emphasis on this one. In your differential diagnosis, there is a differential diagnosis of cellular lesions, supracellular lesions, and then cavernous sinus lesions. So all of these are extremely important. And we have covered it when we covered the CNS. But here the repetition is, so this is a coronal view, and these are the nerves, and you can see third nerve, fourth nerve, and the sixth nerve, and V1 and V2. All of these are part of the cavernous sinus. Here, I just want you to concentrate on a single thing. And this is an exam type of, in your part 1 anatomy, they will ask you this. This is a coronal section. Look at the shape here. Look at the shape. This is the beak of the eagle. If you stretch your imagination, it looks like an eagle. And on a CT scan, you will see it 100% like this. Point to remember that the hypoglossal foramen, the canal, which passes underneath this beak. So this is the 12th nerve which is passing through it. And just superior to the beak is the jugular foramen. So this beak is a key reference point on a coronal CT. This is eagle's beak. Okay, now this is a 3 Tesla MR, so it's much better seen, but on 1.5 also you can see many things. I don't have time but today to show you once again, but you know, all of you tomorrow open a CIS sequence on your packs and go through these. Most of these will be visible even on 1.5 Tesla. So if you see here, we are at the level of the medulla. The key point I want you to remember, because this is an exam point, part 1 anatomy exam. If you see here, this is the clivus, and you see this is the occipital bone, and there is a foramen. So this is the hypoglossal canal. And on this MR, though it is a T2-weighted sequence, you can see the clivus here, and you can see another bone here. This is the cortex, which is low signal. So this is that canal which is visible. So I can ask you this question in the exam. So hypoglossal canal. Of course, in a normal 1.5 Tesla, it is your luck if you are able to see the nerve itself, but you should remember this canal. But more importantly, you should remember it on a CT scan. So we go more superiorly. Now the jugular foramen is coming into view. And there are nerves coming out of the medulla. Look at the shape of this. This is the medulla. And pons, of course, if you go superiorly, so this is pons, right? So I call the pons the fat man. And then if you continue superiorly, this is the midbrain, and I call it the Mickey Mouse. So on a CT scan, this is the Mickey Mouse, which is, you are at the level of the midbrain. Here, you are at the level of the pons, the fat man, and of course, the fat man finishes. So here, you are at the level of the medulla. So now nobody can tell. We know that at this level, the 9th nerve and the 10th nerve and the 11th nerve will come out. On a 1.5 Tesla, nobody can tell what is what. Don't worry about it. Just know, just remember that these are coming out from here. 9th, 10th, and 11th. So the jugular foramen has just come into view. Concentrate on the red dots here. it's a jigsaw puzzle. And don't try to learn each and every thing on that particular slice. Just try to learn one single piece, and then what is around it, and then what is around it. Go up and down, go anterior and posterior, go right and left using your back's function, and try to orient yourself. And gradually, you will learn everything. But if you open a atlas and try to learn whatever is in a cross-sectional in one single view, it becomes very difficult to retain it. So you don't try to do that. Now, this is 1 by 12 means I'm going to show you 12 slices here. And here, our aim is to have a global view. And after this, we will take a break and then come back and tackle each and everything in more detail. So if you see here, we are at a particular level. So there is a landmark here. And the landmark is that we have got mastoid hair cells. And there is something coming here. So this is the anterior cranial fossa, the middle cranial fossa, the posterior cranial fossa, and the mastoid hair cells. Enough for this. Now we go to the next slide. And the first thing which comes to our view is the posterior clinoid process. So the common sense is that here will be the pituitary fossa. Now on the other hand, here, this is the temporal bone, and we have got the petrous apex here, which we covered last time. So the orbit is just coming into our view here. And this is the anterior clinoid process. This is the anterior clinoid process. We go to the next slide. Now what has happened? Here, the petrous apex is still visible. The IAM is visible. The IAM is visible. The mastoid hair cells, mastoid antrum is still visible. Anteriorly, what has happened? That the posterior clinoid process is there, and the anterior clinoid process has come into view. What is medial to the anterior clinoid process? That is the optic nerve. And so this is the optic foramen and the optic canal. Now a sinus, a paranasal sinus is coming into our view. This is air. This is common sense that this has to be the sphenoid sinus, because this is the sphenoid, the base sphenoid. So the orbits are coming into view. We go to the next slide. Now what has happened? The petrous apex is still visible. The IAM is still visible. Rest of the petrous temporal bone is visible. Posterior clinoid. So this is the pituitary fossa. And the sphenoid sinuses are in view. On the other hand, the optic canal is here. Now, lateral to the optic canal, if you look carefully, there is a defect here. You see this thing? So this has to be the superior orbital fissure. So this is the optic canal, and this is the superior orbital fissure. And this is the orbit, and this is the orbit. And this, if this is the pituitary fossa, stretch of imagination, the cavernous sinus is sitting here, and the cavernous sinus is sitting here, and the internocoroid artery is going here. Next slide. So now what has happened? The petrous apex is still visible. And of course, the temporal bone is visible. This is the clivus. And now what has happened? That the more of the sphenoid sinus is visible. The superior orbital fissure, now the optic foramen is gone, but the superior orbital fissure is still visible. So I go back. So you see, this was the optic foramen and the optic canal, and the next slide here, only the superior orbital fissure is there. And this is the sphenoid sinus. Our crista galli in the midline is visible. I told you that this is part of the ethmoid, which has got a lot of fat. and it's a landmark on an MR where it will be high signal because of fat. So this is slide 6. This is the petrous apex. Look at this word, petro-occipital fissure. This should be in your vocabulary. There is a fissure means there is a space there. So this is the petrous apex and this is the occipital bone. There is a tumor which is chondrosarcoma, which is an exam tumor. And the first thing which they will tell you that how do you differentiate between a chondrosarcoma and chordoma is that chordoma arises from the midline here, from the clivus. Chondrosarcoma arises, off center with the epicenter at the petro-occipital fissure. So you must know this. This fissure is between the petrous apex and the basi-occipit. Now here, this is the sphenoid sinus and the superior orbital fissure is visible. Now you see this is the middle cranial fossa. Now the orbit is in the view. This sinus is the ethmoid sinus. So this was the sphenoid and this is the ethmoid sinus. Now we go to next slide. So clivus is coming into view and this is the petrous apex. This is our carotid canal. You can see the carotid canal and you can stretch your imagination that the internal carotid, this is the horizontal part of the carotid canal. It is going like this. It will pass over the foramen lacerum and then go into the cavernous portion. So this is the pre-cavernous carotid canal. Look at this word, spheno-occipital synchondrosis. This word should also be in your vocabulary. Spheno-occipital synchondrosis. This is that synchondrosis which is in the clivus. Remember that in a child, this can be, you can mix it up with a fracture. So part of the sphenoid bone and part of the occipital bone, this is that synchondrosis. Now sphenoid sinus. Now if you look carefully, you can see the optic nerve here. And this is the superior orbital fissure. And then the globes are visible, ethmoid sinus. Actually, you can see the medial rectus and the lateral rectus muscle also. Now, next slide. This is 8/12. You can see the carotid canal once again passing over the foramen lacerum, the cavernous portion. This is the clivus. Now here is the sphenoid sinus. These are the ethmoid sinus. And of course the globe is visible. Medial rectus, lateral rectus. So we are coming, this is the middle cranial fossa. Posteriorly, we can see the jugular foramen here. And we can see the jugular foramen here. If you see, there is a landmark here is a sigmoid sinus, then sigmoid notch we call it, and this is the jugular foramen and the jugular foramen on the other side. You see this pars vascularis jugular foramen. Now we go to the 9/12. Here, more of the clivus is visible. Anteriorly, we can see sphenoid sinuses. The petrous apex is just finishing from view. Anteriorly, we have got another foramen, and this foramen is the inferior orbital fissure. So the globe is here, the ethmoid sinuses, sphenoid, the globe is here. This is the lateral wall of the orbit. Now, key point. This slice is passing through the base of the skull, and you can see the foramen ovale here. So this is an exam type of a, they will ask you what is this foramen, and this is the foramen spinosum. These things are visible on the next slide in a better way. If you see here, this is 10/12, and you can see foramen ovale here, foramen spinosum here. So this is the clivus here, sphenoid sinus, inferior orbital fissure, globe, and glow. Now, we are coming to something very interesting. And so clivus is here. You see this gap? And this gap is, I told you before also, this is the hypoglossal canal. So this is an exam type of a scenario. What is this? And you should know that this is the hypoglossal canal. Now, this is that fissure. The sphenoid sinus is just coming out of so the view, thus finishing, should I say. But the key finding is this thing. You see this thing? So I forgot to mention something else actually. So which is, if you see here, this thing, just one second, let me go up and take you down once again. So this is foramen ovale. Now, look at this one. This is the sphenoid sinus, and there is a foramen here which goes anteriorly. This is foramen rotundum. I go back, and I'll show you, when I show you on a DICOM, then it will become very clear for you. This is the sphenoid sinus. This is foramen rotundum. So if I go back, this is the middle cranial fossa, and at the floor of the middle cranial fossa, just before the floor is the foramen rotundum, which is going anteriorly. So the V2 passes through it, and then come the foramen spinosum and the spinosum and ovale. And here comes another foramen or canal, Vidian canal. So this is a key thing which we will learn today, Vidian canal. And a key structure which is anterior to that. This is the pterygopalatine fossa. So this is 12 by 12, and this is the pterygopalatine fossa. Pterygopalatine fossa is connected to the nasal cavity, the superior meatus here. It opens here. I'll go into details later today. Anterior to that is the maxillary sinus. So I'm going backwards now. So this is the pterygopalatine fossa. And the first connection with the intracranial cavity is the Vidian canal. And then the second connection is the foramen rotundum here. So we will revisit this. So this was an overview. And when we come after the break, we will continue with one thing at a time. It will be a repetition. And the main idea is that this will consolidate everything. So, candidate 1, are you with us?
Yes, Dr. Khan, I am here.
So, madam, let me go to candidate 2. Sorry, time-wise, you were with me for a long, but the format was such that I could not ask you much.
Sure, thank you.
Thank you. So, candidate 2, are you with us?
Yes, Dr. Khan.
Okay. So, I am not sure because the Viva is still a bit away, but it is your luck, whatever comes. So, a repetition. Now, this is the, the hypoglossal canal, and I was telling you that this is an exam scenario, the eagle and the beak of the eagle. This is a coronal section, and the hypoglossal nerve passes through. Now, superior to that or supralateral to that is the jugular foramen, and these are key landmarks for you to remember. Now, if you see here, this is the clivus, and there is a gap here. So this is a hypoglossal nerve, hypoglossal canal. And this, look at this. Now, this is 1/4. So if you see here, this is the jugular tubercle. And this is the basic occipit. And this thing, here you are. If you see here, this is the beak. So this is the hypoglossal canal, and this is the jugular foramen. So a question can be in the exam, what passes through it? And you should know that 9th, 10th, and 11th. And a question passes, name the structure, what passes through it. This is the hypoglossal nerve canal, and the 12th nerve passes through it. So this is a bit of a repetition. You remember, all of you know this. This is easy. This is the occipital condyle, and this is the lateral mass of C1, the atlanto-occipital joint. So this is the jugular tubercle, and the jugular tubercle makes the beak of the eagle, and the hypoglossal canal is under the beak. Jugular foramen is over the beak. Remember it like this. Another point to remember, and this is an important point for the future session, is that the carotid space touches this part of the base of skull. So the hypoglossal nerve indirectly goes into the carotid space. And this concept is important to remember. Now, what we are going to learn is a bit of repetition about foramen rotundum, Vidian canal, the foramen ovale and foramen lacerum on a corona. So you remember that this is foramen rotundum, where the V2 is passing anteriorly. And if you see here, this is the V2 and this is the Vidian canal, and we will see how it looks like on a corona. It is beautifully seen on a coronal CT scan. And this thing is the pterygopalatine fossa. Anterior to that is the maxillary sinus. This is the internal maxillary artery. A repetition here, just to show you the Vidian canal and foramen rotundum. So our area of interest is foramen rotundum and the Vidian canal. Now, if you see here, this is the greater wing of sphenoid. So there is a gap here, and this gap is foramen lacerum. I told you that in a living human being, it is fibrocartilage. So on a CT scan, there will be a gap there. Now, as we come anteriorly, this is key point to remember. If you see, this is the sphenoid sinus. There is a foramen which is inferior to that, and this is the Vidian canal. And let's trace it anteriorly. Next, sorry. So let's trace it. Next slice, it comes inferior to the sphenoid sinus. See this thing and this thing. And you can see the pterygoid plates, the lateral pterygoid plate, medial, lateral, medial. So Vidian canal take-home point is inferior to the sphenoid sinus. On the other hand, the foramen rotundum is lateral to it. So here, this is foramen rotundum, and this is lateral to the sphenoid sinus. Key point to remember. So I repeat, key point to remember on a coronal, that the Vidian canal is inferior to the sphenoid sinus, and the foramen rotundum is lateral to it. We will see a case later on to consolidate this. Now, the foramen rotundum and Vidian canal on an axial slice. So you remember, this is the posterior clinoid, and this is the anterior clinoid. So just medial to that will be the optic foramen, and this will be the optic canal. This is the superior orbital fissure. Now, we are going inferiorly. So now the posterior clinoid passes the pituitary fossa. The sphenoid sinus has come into view, the superior orbital fissure. We are going more inferiorly. Now, this is the floor of the sella, and this is the superior orbital fissure. More inferiorly, superior orbital fissure. More inferiorly, and now you see this side. So the maxillary sinus is here, and you can see this pterygopalatine fossa, and this is the foramen rotundum. Now, if you go back to your coronal orientation, you can see there is the foramen rotundum is lateral to the sphenoid sinus. So must remember that this is foramen rotundum, and I'm still foramen rotundum, and this is lateral to the sphenoid sinus. Anteriorly is the pterygopalatine fossa. And now we are going inferiorly, and here comes our another canal, and this is the Vidian canal, and it opens into the pterygopalatine fossa. So this is key anatomy on axial, and the same thing I've showed you on coronal. Now, this is pituitary fossa, and you know, on a plain film, this is how it looks like, sphenoid sinus. So this is posterior clinoid process. This is the sella turcica, the dorsum celli, the tuberculum celli, the anterior clinoid process, etc. On a sagittal CT scan, this is the pituitary fossa. So in the midline, you will have the planum sphenoidale, and this will be what we call the cribriform plate. And this bone here is the crista galli, where the falx attaches, and it is part of the ethmoid bone. On an MR, and this is what I was talking about, that this is a sort of a landmark crista galli, because it has got a lot of fatty marrow. It will be high signal, and there will be some surrounding fat. So this will be crista galli is high signal. Similarly, clivus is high signal. And this, of course, is the pituitary. So, and this is the cribriform plate of the ethmoid. Candidate 2, VAA case from CNS. There is a tumor here. Because of time factor, I'll describe the sequences for the audience. This is the PD weighted sequence, PD, T2, 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 flare, flare, T1, post-contrast, 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 post-contrast. Can you describe the findings to me, candidate 2? This is a pure exam case, but it is from the CNS world. Over to you.
Sure. So there is a well-defined mass lesion centered on the planum sphenoidally, which is of low signal intensity on T1 and low T2 as well, surrounded by vasogenic edema, distributed bilaterally in the subcortical white matter, and it shows avid enhancement with some non-enhancing parts centrally. So this is most likely a planum sphenoidal meningioma at this location.
Excellent. So the point here was to learn the anatomy. Now, initially, the CNS part of this case, I've shown you when we covered CNS. that when you see this case, it looks there is a lot of edema. And initially on an axial slice, many people will confuse it with a butterfly glioma. And in a butterfly glioma, what happens is that it passes through the genu of the corpus callosum. But if you look carefully, this thing is not extending through the genu even on axial. Actually, it is arising from, there is a dural base to it. And if you see here, this is it. And actually, you can see a dural tail sign here. The key learning point was that it is arising from, if you see here, it is arising from the planum sphenoidale and maybe here also. So what we call olfactory groove plus planum sphenoidale meningioma. So this was just to consolidate the anatomy. Now, so it is arising from here till here and here till here. Okay, this one I will open to the chat actually. Just one second. I think I have to show you I have to show you just one second. I have to show you DICOM before I give you the exam. So candidate 1, correction candidate 2, can you see my DICOM viewer?
Yes.
Okay, so here I am going to go through key points. Now, so you can see a single axial sequence, correct? Candidate 2?
Yes.
Okay, so this is going to be a repetition, but this is going to be DICOM base. So this is, so base of skull. Now we are here and we are here in the cervical spine. This is the dense and this is the C1. We are going into the foramen magnum. And superior to that, so let me, I think it is, show you. So if you see here, if you see here, I am coming to the clivus. And let me come on to. So I am coming to the, just see this reference mark. And I am coming towards the clivus. Here, there is going to be a gap. You see this gap? So this gap is going to be the the hypoglossal canal. And just a few slices superior to that will be this thing is the jugular foramen. Don't confuse it with this structure, which is just anterior to that, which is the carotid canal. So coming back, our main aim was to see the hypoglossal canal. You already know the jugular foramen. Now we will try to see the foramen ovale and spinosum. So if you see here, this is the ovale and the spinosum. Now, if you see here, this is the middle cranial fossa. So here you are. This has to be the foramen rotundum. This has to be the foramen rotundum. And this is the sphenoid sinus. Now, if I go further inferiorly, then we have got the Vidian canal here. If you see here, this is the pterygopalatine fossa. So the Vidian canal, and then as I go superiorly, foramen rotundum, and this of course is the middle cranial fossa. As far as orbit is concerned, if we go superiorly, here we are, posterior crinoid process, anterior crinoid process. This thing here has to be the optic nerve and the canal. And as I come inferiorly, this gap here is the superior orbital fissure. And as I have come more inferiorly, just at the level of the foramen rotundum than the inferior orbital fissure. So we will go to a coronal. Let's go to the eagle. So now, if you see here, this is that eagle and the beak. So this thing is the hypoglossal canal, and here will be the jugular foramen. And the key point which I want you to remember on this coronal is the foramen rotundum and the Vidian canal. So if you see here, this is the sphenoid sinus, and this is the sphenoid sinus. Inferior to the sphenoid sinus, you can see this foramen, this thing. So this is the Vidian canal, and it opens into the pterygopalatine fossa. On the other hand, lateral to that, which is this one, is lateral, and you can see it opens into the middle cranial fossa. So that is the foramen rotundum. So this was a bit of a repetition, and now a quiz. And this quiz, I think, will be open for the chat. So candidate 2, you can see a DICOM skull base.
Yes.
So now I'll ask you, because there is too many questions, because of time factor, I'm going to ask you specific questions. Number 1, please. What is number 1?
Me or chat?
Okay, chat, please. Chat, please. So, good. Number 5. Number 5. Vidian. Number 2, please. Number 2, this thing, spinosum. Number 3, carotid. Number 4, sigmoid notch. Okay. And number 5, jugular. So these are the correct answers. So this was the jugular, this was the carotid, and this was the sigmoid notch, where the sigmoid sinus is, Vidian, foramen ovale, and spinosum. Next is a sort of a repetition. Here, I don't think so there is much new. So this is number 4. What is number 4? Excellent. So rest of the stuff, I think, because of time factor, I'll just show you. I think this was similar to the previous one: ovale, spinosum, jugular, foramen, and the horizontal carotid canal. Yes, please. What is number 1? Rotundum. And what is number 3? So this thing here, carotid. Okay. So now, key point to remember here is that this is rotundum. Superior orbital fissure, slightly more superior, right? Now, this is sphenoid sinus, and lateral to that is foramen rotundum. So I go back. This was Vidian. you see the sphenoid sinus is not visible to you. So we are inferior to that. Now the sphenoid sinus is visible, and this is rotundum. Number 3, please. Number 3. Excellent. So this is rotundum, and again, this is the other side. The patient is slightly tilted, and this happens in the real world also. So the right and left will not be symmetrical. And so the key point is that this is lateral to the sphenoid sinus. So I go back that Vidian will be inferior. This is Vidian, inferior to the sphenoid sinus. And rotundum lateral. So on this side, because of asymmetry, it is visible. And next slice, it is visible on this side. Now, what is this? Number 4. Yeah, if you see here, this is the fossa, right? So this has to be the posterior clinoids. So next slide. What is number 2? Okay, now it is not written in the quiz, but I am asking you, look at my mouse. What is this? Where my mouse is? There is a foramen. This is optic. Yes. Please remember it is medial to this. And the superior orbital fissure will be lateral to that. This thing will be the superior orbital fissure, and this will be the optic foramen and the optic canal. Okay, now coronal. So what is number 3? Number 3. Vidian, very good. Now you are experts. And what is number 2? You know this bone, yeah, lateral pterygoid. So what is this? Number 1. Very good, rotundum, and it is lateral to the sphenoid sinus. So we are coming to the good old eagle. So what is the name of this bone? Number 2. Name the bone. Excellent. So this is the jugular tubercle. This is beak is the jugular tubercle, and this is the hypoglossal canal. What is number 6? Excellent. And this, of course, what is number 3? Right, occipital condyle and rest. Okay, well done. This is, of course, easy. And this is the posterior clinoid, this is the plenum sphenoidale, and the rest of the stuff I think you people already know. Okay, so we have covered base of skull anatomy. And now let's go for a bit of viva. Candidate 2.
Yes.
You are with me. Okay. So now, because of time factor, I'm going to describe, some of these are not classical viva cases, but I will ask you leading questions. This is a T1 post contrast. This is a T2. this is, disregard this CT scan, forget about this CT scan. So on this T2 and on this T1 post-contrast, this patient is a 32-year-old female, trigeminal neuralgia on the right side. Describe your findings to me, please.
So there is a heterogeneous T2 and heterogeneously avidly enhancing mass lesion, which is paramedian, centered at the level of the sphenopetrous fissure and seems to be extending anteriorly up to the level of the Meckel's cave. This seems invasive and encroaches on the brainstem. At this location, differential diagnoses include chondrosarcoma and chordoma.
Okay, if you see here, whatever you have said, I take it for the simple reason that I've just given you a single slice, so I do understand that you cannot see. My point was just a bit of anatomy here. This, by the way, is a meningioma. The point is that if you see here, this thing, this T2 weighted, there is CSF here, and you can see this low signal here. So this is the Meckel's cave. And this here, there is enhancement. You can see that this is going into the Meckel's cave. You can imagine that the cavernous sinus is sitting here. So this is a meningioma. So don't worry, it is because this was, okay. Let me go through it. T1 weighted sequence, T2 and T1 flare, T1 post-contrast, coronal post-contrast. What is happening here? Can you describe your findings, please?
There is a heterogeneous mass lesion, which is centered on the left cavernous sinus, indents on the mesial temporal lobe, and extends posteriorly up to the anterior to the anterolateral to the pons, and shows avid enhancement. On coronal imaging, this seems to be extending inferiorly. So differential diagnoses include schwannoma. I don't think that it's extended to the jugular foramen here.
Jugular foramen. Anatomy.
No.
Jugular,
I think it's cavernous sinus, right? That's it.
right. So if you see here, there's a bit of anatomy here. The anatomy is that there is a mass here. It is centered in the cavernous sinus, and it is showing all that enhancement. So this is the carotid artery. And now what is happening, that if you see this T2 weighted sequence, it is going into the neck actually here. Now this coronal tells you everything. So what is happening, that if you see, this is the cavernous sinus on the normal side, this is the pituitary gland, and on this side there is a mass. And you can see that this, you can stretch your imagination that this is passing through something and going into this space. This space has to be the masticator space. And this is the CT of the same patient. So this is vagal schwannoma. Correction, there's a typo here. So this is V3 schwannoma. It is not vagus nerve, it is the fifth nerve, V3 mandibular division. And it is causing this expansion, case from American College of Radiology. So this is, you can see that this is the foramen ovale, and you can see how it is causing expansion. And this is one of the key findings of schwannomas, which will expand the bone because they are not aggressive lesions. And on a CT scan, this is how it looks like. So anatomy is the key. So this is a third nerve schwannoma or a mandibular schwannoma. This case is a PET scan from our collection. And what happened was that in this case, the patient had lymphoma, was treated, and then developed some lymph nodes. So they did a PET scan. Now, on this PET scan, look at this sequence. And what do you think is this and this and this where I'm pointing out a candidate to?
Lymph nodes.
Lymph nodes, and they are sort of
Nodal masses. Yeah.
yeah. What do you think about this thing where I'm pointing out?
Yeah, there seems to be an intracranial component which is extending through a foramen here.
What will you do?
I'd like to correlate with the cross-sectional imaging.
So I have given you this MR. So look at this axial and look at this coronal. Just describe it for me and look at this coronal also.
Yes. So an enhancing mass is seen related to the left cavernous sinus, extending inferiorly through the foramen of valley, possibly into the...
Excellent. So the idea here was to consolidate the concepts of anatomy. And this is, if you see here, this is what happens. If there is a tumor sitting in the masticator space, it is abutting the foramen ovale, and there is a concept of perineural spread. And in our case, what is happening, if you see here, this is not a fat saturated sequence. Classical head and neck imaging has to be fat saturated. But you can see that there is a lot of enhancement in the masticator space. And with that, this enhancement goes into the cavernous sinus. The coronal tells you the connection, and that connection is through the foramen ovale. So this is what has happened, just to consolidate the anatomy. Now, similarly, another part of anatomy is the styloid foramen, where we know that the seventh nerve goes into stylomastoid foramen into the parotid space. And this case I showed you last time, where this is the parotid gland. There is a adenoid cystic carcinoma, and this carcinoma is spreading. What happens is that it is going into branches of the V3 mandibular division as well as the seventh nerve. Though the imaging is not with fat saturation, but you can see some enhancement. Now, if you look carefully, you can see a bit of enhancement here. This is the Meckel scale. And then you can see this enhancement all the way going into the internal auditory canal. If you look carefully, you can see this enhancement of the tympanic portion of the facial nerve. So perineural spread. And the concept is, if you see this diagram, that it goes through the facial nerve all the way intracranially, and as well as the same concept as the previous case. So it is going here, and you can see that there is enhancement here, and it passes through the foramen ovale also. So again, the same concept, which can be checked in the exam. Now, a repetition, because not a repetition, but a revision quickly of the jugular foramen mass. We have already covered it. Extremely important for your exam. When a mass is centered on the jugular foramen, this is the differential diagnosis. And the most important ones are the glomus, vagale, or jugulare, or a schwannoma. And I told you last time that the glomus tumors, the name changes according to the location. Glomus tumor is the same thing as a chemodectoma in the adrenal and head and neck. We call it a glomus tumor. If it is at the carotid bifurcation, we call it a carotid body tumor. If it is at the jugular foramen, we call it glomus jugulare. If it is in between, we call it a glomus vagale. But this one, if you see this one, what is happening, that from the jugular foramen, part of it is going into the middle ear cavity also. This one is known as glomus jugulo-tympanicum. And of course, there is another one which will only be in the middle ear cavity, which is just known as glomus tympanicum. Now, key exam point on a CT scan is that a glomus tumor is a highly vascular tumor and it will cause erosion of the bone. On the other hand, this is a schwannoma of the jugular foramen, and you see how it is causing expansion of the bone, similar to this case which we saw. So this is schwannoma behavior. On the other hand, a glomus tumor will cause permeative bony destruction. So remember this word. It will cause permeative bony destruction. Of course, the MR findings, etc., we have already covered, but today the idea was just to revise it. Candidate 2. I've given you a CT scan, MRT1, CT scan, MRT2, MRT1. Over to you.
So there is an erosive soft tissue mass at the skull base on the right side, which is causing expansion of the jugular foramen and erosion, permeative erosion on the petromastoid bone. This is of low signal on T1 and hyperintense signal on T2. We don't have a post-contrast imaging here. So differential diagnosis of a tumor at this location include glomus jugular and schwannoma. Given the erosive pattern, glomus jugular is favored over a schwannoma. Other differential would be petrous epicitis.
Now, the key thing in head and neck imaging is what is the epicenter of the lesion. This is the key, and your differential will completely change because of that. Now, if you look carefully, this is a T1 weighted sequence. So candidate 2, this marrow signal, where is it? Where my point, you know, where I'm pointing, what is this?
That's a Bayes sphenoid.
Bayes, should I say Bayes occipit, because we are in the clivus, right?
Yes, true.
Lower portion. Can you correlate it with this CT scan? So we are at the, can you see it here? We are in the clivus. Now, key point to remember is that we are, now this is medulla. And look at the marrow. Please remember that T1 weighted sequence is the best sequence to initially pick up marrow abnormalities, because the normal signal, which is high on T1 because of fatty marrow, that is lost. Now you can see that there is a lesion sitting here. Part of the clivus is involved, and from there you can see it here. So it might be invading, you are absolutely right, it might be invading the petrous apex, but it is also invading the clivus. So it is sitting somewhere here. I understand that we cannot get a, we will just give a differential diagnosis. But location-wise, the key learning point was, look here. This is the part of the clivus, this is the petrous apex. The clivus here is eroded, and part of the apex is also eroded. Now, give me a bookish differential diagnosis of this type of infiltrative lesion at the base of skull.
We have chondrosarcoma.
Excellent.
Glomus jugular. And
why do you say glomus jugular? Anatomy-wise, are we at the jugular foramen? This is the key point for you to remember.
Yeah, it's more anterior. Yeah, I think.
Yeah, so this is in head and neck. This is critical. You have to be absolutely, sure where you are. Of course, there will be cases which will be completely infiltrative and you will not be. But in this case, you can either go that this is petrous apex and the adjacent clivus. Jugular foramen is not involved. Agreed or not?
Yes.
So let's do an exercise on first of all the differential diagnosis, and then we will come back to this case. In your Chapman, there are lesions in the clivus. Now, skull-based lesions not specific for clivus. Key point. You know things like benign things like fibrous dysplasia or Paget's, but look at these ones. Whenever you find infiltrative lesions, you can keep these things in your differential. Metastasis, lymphoma, myeloma. So these three you can definitely keep it. Now there is a tumor. When clivus tumor, these two are the main differentials. Other than these things, chordoma. The key point, chordoma versus chondrosarcoma, is that chordoma is in the midline. It arises in the midline at the spheno-occipital synchondrosis. Here comes your anatomy. You remember that clivus is made up of basi-sphenoid and basi-occipit. And the synchondrosis between the two is known as spheno-occipital synchondrosis. So chordoma arises from the midline. Chondrosarcoma, on the other hand, is para-midline. And it arises, I told you, you remember, there was what we call the petro-occipital fissure. So it arises slightly off-center. Now, look at this picture. And so part of clivus, part of this. This is that fissure, right? This is that fissure. So the epicenter is here. So you have to discuss the differential in this fashion. Of course, you can keep metastasis, myeloma, lymphoma, all of these in differential, but chondrosarcoma as well as chordoma. Now, one of the key points to differentiate between the two is chondroid matrix. But the but is that in a chordoma, there can be similar, what happens in a chordoma? Just remember it like this, that chordoma is a midline tumor. It can arise anywhere from the clivus till the sacrum. And here you are, here is a case from sacrum. You see, this is a case of the sacrum. Now, look at the radiology of this on a CT scan. What you see is that there is liquefaction of the bone, and the destroyed bone fragments are sort of floating in it. So this is how a classical chordoma behaves on a CT scan. Look at this case here. Here is a midline tumor which is replacing the clivus, and you can see a lot of necrosis, and there is punctate, floating bones within it. The chondrosarcoma, on the other hand, can have chondroid matrix. So this is indirectly, it looks similar to our eyes as this one, which was liquefied bone. So the key differentiating point is that it is off center and chordoma is here. So coming back, what we are discussing is to develop the art of differential diagnosis. In this case, nobody can be, this was a chondrosarcoma, of course, nobody can be absolutely specific. So you have to give the logic to the examiner. First of all, where the lesion is. And the lesion was partly involving the clivus and partly the petrous apex. And then develop the differential diagnosis. And take the help of Chapman, clivus, and then chordoma, chondrosarcoma, lymphoma, myeloma, all of these metastases, you can keep it. But this is the key. So this was clivus lesions, unifocal skull-based lesions. Again, any multifocal lesions can occur like this. Candidate 2. Is the clivus normal?
There is loss of the normal fatty marrow of the clivus.
Excellent. Differential.
So soft tissue replacing the clivus, differentials would include chordoma, lymphoma, and metastasis. This is in all patients, so myeloma and metastasis would be in the differentials as well.
Excellent. So this per se becomes an exam case on a sagittal, and your mind will be, remember in exam what will happen. This is a brain MR. and you are looking at, corpus callosum is normal, this is normal, that is normal, and actually the pathology is sitting here. So clivus should be part of your protocol. Look at the clivus. And if the marrow is gone, then, means the differential which you have just elaborated. And you see the CT scan, look at the sensitivity or the specificity is poor, isn't it? There is some soft tissue there. But the differential which you have given us, that is absolutely fine. Midline, and this is the same differential as before. This is your last case, candidate 2. Then I'll go to candidate 3, maybe give a break and then go to candidate 3. Now, let me talk through this case for the audience. T1 weighted sequence, flare sequence, T2 weighted sequence, PD weighted, and SWI sequence, which is susceptibility weighted image. Anything wrong in the skull vault? Leading hint. Look at the skull.
Left, yes, left temporal.
So
mastoid portion of the left temporal, yeah, seems to have an expansile soft tissue lesion there.
which portion?
I think it's the not mastoid, the squamous portion of the temporal.
Squamous. Okay, if you include the squamous, I will totally agree with you. But what about the sphenoid itself? You see this?
Sphenoid central.
Do you see this?
Mm-hmm.
This is the middle cranial fossa. Agreed. This is the middle. So this is making portion of the floor of the middle cranial fossa. Part of it, you are right, might be temporal, but the sphenoid will also be there. Now, on this MR, suppose you got this case in the examination, and you have described that there is some bony expansion here, and what will you do then? What will you ask for in the exam?
I would ask for a CT scan to correlate.
Here you are. So I've given you a CT scan.
So on CT scan, this expansile lesion shows ground glass appearance, which is suggestive of fibrous dysplasia. Differential diagnosis would be Paget's disease, less likely.
Now, how do you differentiate between Paget's disease and fibrous dysplasia?
Fibrous dysplasia will show a homogeneous ground glass appearance of the bone. Paget's disease will show thickening of the cortex and coarse trabeculation, and it's not a typical location for Paget's here. Usually the calvarium rather than the skull base in the skull.
Okay, so fibrous dysplasia, please remember a few points. It is not at all a must for fibrous dysplasia to be ground glass. Remember that. And now the first thing is that in your Chapman, go to read in your own time from Mendel, because mandible and maxilla. So you have to have a clear-cut concept about differentiation between fibrous dysplasia and Paget's disease. Some of the points which you told us are fine, but I want to add on that. Now, please remember that fibrous dysplasia is quite common in the head and neck region. Look at this figure. 25% of monoostotic fibrous dysplasia is face and calvarium. And in polyostotic fibrous dysplasia, up to 50%. Now, the key point to remember is the radiology is a spectrum. Fibrous dysplasia can be cystic. It will be completely lucent. It can be what we call ground glass or pagetoid, which is what you saw, or it can be sclerotic. The lytic one is quite active disease. It is a dysplasia. It is a developmental thing. And as the patient grows till the young, till about 20s or so, it is very active. So normal marrow is replaced by a bony cyst. We have covered this when we were covering the MSK. But the radiology is extremely important. It can be lytic, it can be ground glass, it can be sclerotic. Remember that. Now, one of the key factor is age. So fibrous dysplasia, young age group, Paget's disease, old age group. Number two, you were absolutely right that fibrous dysplasia, usually facial skeleton is involved. In Paget's disease, it is mostly calvarium or the temporal bone. There is a, please go back to the basics of Paget's disease. You remember that Paget's disease can also be lytic completely. And then it can be mixed. So that kind of Paget's disease will give you a cotton wool type of an appearance. Now coming back to our case, so it was not characterizable on MR. You did the right thing. You asked for fibrous CT, and this is a case of fibrous dysplasia. And on the other hand, look at this case. This is a case of Paget's disease. Look everything. This is a 71-year-old, and you can see, that cotton wool type of appearance. Everything, whole of the calvarium is involved. So candidate 2, thank you very much. Candidate 3, are you with us? No?
Dr. Khan.
Candidate
Yes,
3, are you with us? Yes?
Yes.
Okay. This is a case of candidate 2, thank you. And I'll just show you one case and then we'll go for a 5-minute break. So candidate 3, this is a case of fibrous dysplasia. Patient presented with a lot of facial pains, etc. Over to you. What has happened?
I believe there is a destruction of the ethmoidal sinus, a lytic destruction of the ethmoidal sinus, and bony expansion of the greater wing of the sphenoid, the left greater wing of the sphenoid. Can see.
So what's happening here?
So there appears to be lytic destruction of the posterior ethmoid as well as the pterygoids around that area.
So
And
what is your conclusion?
I'm not sure. I think it looks like a nasopharyngeal cancer here, but
What is the unifying diagnosis? Can there be malignant transformation in a fibrous dysplasia?
yes, I believe this is a malignant transformation of.
What is the most common? This is an exam question. What is the most common, tumor, malignant tumor, which?
Osteosarcoma.
Excellent. So this is a case of Paget's disease with malignant transformation. Fibrous dysplasia with malignant transformation. Please remember the same thing can happen with Paget's also. And it is rare, but it can happen. And you can see this bony destruction involving the lateral wall of the maxillary sinus and other parts of anatomy. But so please remember that when you pick up this kind of a lesion in your exam, keep looking, the satisfaction of such, and there might be something else happening. So it's not simple as that. So that was the idea to show you this case. 5-minute break. Candidate 3 will continue with you. In case. So let me take you through this case. Can you hear me?
Yes, I
And can you see this 16-year-old epistaxis? Correct?
yes.
Okay, so all of you please concentrate on this case, and this is a very good case to learn anatomy. Now, this case, what has happened is that this patient has come, the patient is only 16 years old, has come with epistaxis. So this is fat saturated T1 weighted post contrast sequence, and this is the method to do post contrast in head and neck. It has to be fat saturated. Now, if you look carefully, what is happening, that just concentrate on these axials. Now, if you see here, this is the nasal cavity, and there is some enhancement here, some enhancement here. Now, if you look carefully, enhancement is going here, and here is the maxillary sinus. Next slice, this is the maxillary sinus, and there is enhancement here, enhancement here. Compare it with the normal side, and you can see that this is the maxillary sinus. There is something normal here, right? And something is sitting there. Just on these 3 sequences, with this kind of clinical, what comes to your mind, candidate 3?
Okay, what comes to my mind is with this clinical information is juvenile angiofibroma.
Very nice, well done. Describe the lesion for me.
So these are the axial MR images, coronal and then sagittal. On the axial images on top.
I want you to concentrate on these axial. Nothing
okay.
else.
Okay. On the axial, there appears to be a high signal lesion, an enhancing lesion extending into the posterior nasopharyngeal space, as well as posterior to the left maxillary sinus, and it shows avid enhancement.
Okay.
So with these features and clinical present.
You see, you use the word, I think you use the word nasopharyngeal space, correct? Nasopharyngeal space. Can you reconsider this terminology?
Postnasal space.
Postnasal space, okay. Good, well done. We'll come back to this. Well done. So, and your diagnosis was spot on, where you, so there is a tumor in this age group. It's an Aunt Minnie type of a case. Clinical scenario, should I say, that there is a tumor, nasopharyngeal angiofibroma, and can this happen in girls? Candidate 3.
I think can happen in both. I'm not sure.
Boys only. So yeah. So now, or indirectly males. Now, if you see here, this is the lesion. It goes. So we are going to learn anatomy on this case, and it goes here, posterior to the maxillary, and goes here on the coronal and on the sagittal. So let's go back to the anatomy. Now, this is the anatomy of pterygopalatine fossa. Pterygopalatine fossa is the crossroad in head and neck, and it has got connections everywhere. It is like a big railway junction. So what happens is, this is the so can you please mute yourself for the time being? So this is the V2 passes through foramen rotundum, passes here. Now this thing is the pterygopalatine fossa, and in our case the tumor was sitting here. Now This is the pterygopalatine ganglion, and then the nerve is passing anteriorly through the. Now, if you see this diagram, it tells you everything much more beautifully. If you see foramen rotundum here, look at this nerve. Ultimately, it will go into the orbit, and or the branches will go into the orbit. It will, it will give a ganglion, etc. The branches will go. Otherwise, the main nerve is finishing here. This is the Vidian canal, which is coming into this. Pterygopalatine fossa has got connections. Where are the connections? With the orbit, through this, the fissure, and then through the middle cranial fossa, through foramen rotundum, as well as Vidian canal. Laterally, it opens into the nasopharyngeal masticator space. So if you go here, this is the terminology to be used is nasopharyngeal masticator space. So if you see here, this is the masticator space, and this is the level of the nasopharynx. So we call it nasopharyngeal masticator space. It just opens here, and this opening is through the fissure here, just an opening here. Medially, now this concept is important for you to remember. Medially, it is connected to the superior meatus of the nasal cavity. So the nasal cavity is in our curriculum next time. But in nasal cavity, there is an inferior meatus, middle meatus, superior meatus. Actually, what happens in nasopharyngeal angiofibroma, that it arises from the nasal cavity. There is a connection between the nasal cavity and the pterygopalatine fossa, which is known as sphenopalatine foramen. It has got a membrane there. It just passes through it. It is very vascular. It is like a glomus jugulotympanicum type of a behavior. So it goes from there into this. Now the connection is open on the lateral side with the nasopharyngeal masticator space. Anteriorly is the what we call the maxillary sinus, and it has pushed the posterior wall of the maxillary sinus anteriorly, and posteriorly it is connected with the middle cranial fossa through the Vidian canal and the foramen rotunda. So we will see a CT scan of the same case. One connection of the pterygopalatine fossa, another connection which I forgot to mention is that through the pterygopalatine canal, it is connected to the oral cavity. It opens into the oral cavity. So it passes, there are nerves and vessels which passes through the pterygopalatine canal. The palatine vessels, it goes into the heart palate. So indirectly, the connections are extensive. Look here, it is going into the heart palate. So connections with the middle cranial fossa, with the orbit, with the nasopharyngeal masticator space laterally, with the nasal cavity medially, and inferiorly with the heart palate or the oral cavity. So these are the connections. And the internal maxillary artery is here. It is a very vascular tumor. So look at this case, and we will compare it with the normal side. This is the CT scan of the same case, and this will teach you everything. If you see here, look at this soft tissue. So this is the nasal cavity, and the tumor is arising from the middle meatus. Correction, the superior meatus. Compare it with the normal side. There is a foramen here, which is known as sphenopalatine foramen. This foramen has got a membrane actually. Technically, it's not a foramen in a normal adult. But the tumor from here has gone here. Now compare this side here. So this is the pterygopalatine fossa. And as I am going inferiorly, Now see that the posterior wall is displaced here. This is the normal side. There is a foramen coming here, and this is, on the other hand, the tumor is expanding this fossa. Now, if you see here, look at this. We are more inferiorly. This is the maxillary sinus, and this is the pterygoid plate. Look here, it is causing expansion. And as we are going more inferiorly, look at this. And this is that pterygopalatine canal. Look at this canal. And this canal is ultimately going to open into the hard palate. So this was the hard palate. It has opened here. This has shown you the connection. The tumor is not extending there. On the other hand, I come back, and now we will see what is happening to the Vidian canal and the foramen rotundum. So for that, we will see the corona. Now on a sagittal, if you see here, this is the maxillary, and this is the tumor sitting here. And on a coronal, if you see here, now this is the tumor, but our aim is to look at the Vidian canal and the foramen rotundum. Now remember that this, on the lateral side of the sphenoid, is the foramen rotundum. This is foramen rotundum, looks normal. Now look at this. This is the Vidian canal. And you can see that this is the Vidian canal on the right side, and this is where the tumor is. So candidate 3, what is happening here?
There is expansion.
Excellent. So this tumor
and widening of the left Vidian canal.
Excellent. So this tumor is going into the Vidian canal. And this is the pterygopalatine fossa. When you get this in Viva, the examiner might ask you a few questions, because there is a bit of role of, this is a very vascular tumor, and before surgery also, it is embolized, and this is the internal maxillary artery, which is showing this on an external, this thing, what we call a angiogram. From here, we come to the last part for today. Part of the anatomy of the orbit is already covered. It is going to be a consolidation and repetition, and then we will see a few Viva cases. Now, this is the bony anatomy. This is the medial wall. This is the floor. This is the roof, and this is the lateral wall. Now, anatomically speaking, the medial wall is made up of quite a few bones, this frontal process of the maxilla and the lacrimal and the ethmoid. But the key bone for you to remember is the ethmoid, because the ethmoid sinus is sitting here. And this is known as lamina pepritia of the ethmoid. It is a very thin bone. And when we will cover the paranasal sinuses in next session, we will see a few cases where there is subperiosteal abscess, etc. But this is the medial walls. Let's keep it simple. The lacrimal sac is here. The lacrimal gland is here. Please remember, lacrimal gland is sitting here. Supralateral lacrimal sac is sitting here. Now, look at these foramen. You remember, this is the optic foramen, and this is the superior orbital fissure. Please remember that the optic foramen is completely in the lesser wing of sphenoid. And the bone, this optic strut, is the bone which is part of the lesser wing, which separates the optic foramen from the superior orbital fissure. So this is the superior orbital fissure. Just a recap that the optic nerve and the ophthalmic artery passes through this. In superior orbital fissure, radiologically speaking, other than the nerves, the most important thing which passes through it, because nerves we don't see on our imaging, the most important thing, and this is an exam thing, is superior ophthalmic vein. Please remember that the superior ophthalmic vein is a big vein, and I'll show you a few VAA cases about it. And this passes through the superior orbital fissure. Other than the cranial nerve 3, 4, 6, and V1, all of them pass through it. Superior orbital fissure, if you can remember it like this, is a fissure between the lateral wall and the roof. Inferior orbital fissure is a fissure between the floor and the lateral wall. Inferior orbital fissure has got very small branches, nerves and vessels, etc. Radiologically speaking, we are not very much interested there. So, but you should know the anatomy, that there is, nothing big as far as radiology is passing. So this is the lateral wall. Now we are not interested in inferior orbital foramen. Now this is the structure of so this is the globe surrounded by muscles, and this is the optic nerve. So here is a bit of repetition of the main foramen. Now, key point to remember, this is a landmark for you. Now, this is anterior clinoid process and the optic strut. This is a key landmark for you, because medial to that is the optic canal, and the optic foramen will be here. And lateral to that is the superior orbital fissure, which makes sense. If you go back to this diagram, this is medial and this is lateral. So just remember this. This is canal. If I go one slice superiorly, which is not available here, you will see the optic foramen. Then is the canal. This is the optic strut. And it will make the superior orbital, the anterior clinoid process. And this is the superior orbital fissure. Actually, you can see a vein passing through, and that vein is the superior ophthalmic vein. If you see here, this is the superior orbital fissure. Superior orbital fissure. Next slice. And then the next slice. And here is the inferior orbital fissure. So the foramen rotundum, and so this was part of the the superior most extension of the pterygopalatine fossa, and then the inferior orbital fissure. So the connection between the pterygopalatine fossa and the orbit. So I repeat, optic canal, optic foramen will be the medialmost portion, superior orbital fissure, and more inferiorly, where you can see the foramen rotundum, the inferior orbital fissure. And of course, our good friend, the pterygopalatine fossa. So this is the Vidian canal, the foramen rotundum. This is the optic canal, anterior clinoid process. And more anteriorly, we can see the ethmoid sinuses, orbit here, and so we are quite anterior here. So this is the lacrimal gland. As far as rest of the structure of orbit is concerned, it's easy. This is the globe, and sclera is outside, then the choroid, then the retina. This is the nerve, and then there are extraocular muscles. And all of these muscles at the apex of the orbit, there are muscles, and with that is fibrous septa. So they are attached like this, and it surrounds the optic foramen as well as the superior orbital fissure, etc. Anatomy is very easy, and we are not going to waste time, because we know that the main muscles, medial rectus, lateral rectus, inferior rectus, superior rectus, rest of the muscles are less important for us. Now, this is the optic nerve, and now you can see what is happening, that this is the nerve. So optic nerve has got various portions. This is the orbital portion. This is the canalicular, so it passes through the canal, and then there is intracranial portion. If you see, this is the optic nerve. Surrounding that is the CSF space. Key point to remember that optic nerve is an extension of the brain, so it carries the CSF with it. So the arachnoid, etc., is there, and there is a subarachnoid space. This is the optic nerve head, and the medial rectus, the lateral rectus, the orbital fat. Now, if you see here, on a T1 weighted sequence, we are quite anterior. This is the globe. This is the lacrimal gland. We go slightly posteriorly. There is fat. This is the optic nerve. Inferior rectus, lateral rectus, medial rectus, superior rectus. Other muscles, I'm not giving much weightage here. So one key point, exam point to remember is that muscles, they are attached to the globe. At this point, there is no muscle. It is tendon. And this is important for you to remember, because to differentiate between orbital pseudotumor and, thyroid ophthalmopathy, etc., that is a discriminator which you should know. We'll come back to this point. Now, look at this one, where this is the optic nerve, and there is a subarachnoid space around it. Optic nerve, subarachnoid space, subarachnoid space. On this contrast enhanced CT, the only point I want you to remember is, look at this. This is the superior ophthalmic vein. And if you look carefully, this is the fissure. So, and it will pass through it, ultimately will pass into the cavernous sinus. So please remember that. And that is why in an exam case, orbital infections can cause sinus thrombosis, cavernous sinus thrombosis. Okay, candidate 3. Okay, you just 1 second. Let me think how many cases are there. Okay, just candidate, is candidate 4 with us?
Yes.
Okay, so candidate 4, just stay with us. Maybe I'll give you some cases after about 5-7 minutes. So candidate 3, are you with us?
Yes, I'm here.
Okay, sorry, the format is such that you people are waiting mostly, but now I'm going to show you a few cases, viva cases from the orbit. This slide, whatever is written on this slide is absolutely pearls to remember. And everything is important for you to remember. Most common globe tumor in children, retinoblastoma. Most common benign congenital lesion, dermoid. Most common primary intraocular malignancy, look at the word malignancy in adults, is uveal melanoma. Most common intraorbital mass, so this is the word is mass in adults, is idiopathic orbital inflammatory disease, IgG4 related disease. Also previously we used to call it pseudotumor. Most common orbital tumor, so this is not a malignancy but tumor written here, is cavernous meningioma. Most common cause of unilateral or bilateral exophthalmos is thyroid orbitopathy. Take a screenshot of this. Now, the differential diagnosis in your previous Chapman, it was given in 1 page, which also gives you a global view. In the current Chapman, you will see that each heading is a different heading because there is too much under all of this. The orbital lesions, and this is what the key point is, as I was telling you, that in head and neck radiology, you have to place the lesion at a particular, space or location, and then tackle the differential diagnosis. And then From the relevant differential diagnosis, the radiological and the clinical features, you will give a differential diagnosis. So in orbit, we divide them into these 4 components. And those lesions which are arising from the globe, then intraconal. Now, what is the cone? Cone, that muscles surrounding the what we call the orbit. Intraconal means something which is inside it. Of course, optic nerve and nerve sheet is inside it, and there is orbital fat also inside it. So this is intraconal lesions. And then there are conal lesions. So what is the cone? Cone is the muscles. So there is a differential diagnosis. Extraconal. Anatomically speaking, extraconal is only the lacrimal gland and the fat. However, you can imagine that from the surrounding structures, many things can infiltrate into the extraconal space. So one key exam point is that a few things will, if you see the differential diagnosis, they are in each heading. Conal lesion, orbital pseudotumor, so lymphoma, sarcoidosis. And you will see that these 3 are here also. And actually you can add it into this one also. So it's a good, thing to remember that these 3, you cannot go wrong with these 3. Other things, we will see a few cases. So look at this in your current book, orbit lesions arising within intraconal fat. And these are the ones. Please also remember that in CNS, when we covered CNS, we have already covered the optic nerve lesions. For example, optic nerve glioma. And we have covered it in detail, where this is a glioma, and we have covered it particularly in relation to what we call NF1, where the definition of NF1 is that if a person has got 2 or more than 2 of these, and one of them is optic nerve glioma. So I am not at all going to revise them in detail, but we have covered it in CNS. So I just wanted to reiterate that optic nerve glioma, you must remember. And there are, of course, a huge, radiological features of NF1, etc. Please remember that in NF1, there can be bone dysplasias, and one of them is sphenoid wing dysplasia, where simply the sphenoid wing is not present. It is absent like this. So these cases we have done. And then optic nerve sheet meningioma, which gives you this tram track appearance and enhancement. Now, if you look carefully on this case, we have done this in CNS. You can see that there is enhancement of the meninges surrounding the optic nerve, and this enhancement goes all the way here. This is the pituitary gland, so it is going through the optic foramen. And on a coronal, this is a post-contrast fat-saturated T1. You can see all of the meninges enhancing. So this is optic nerve sheet meningioma. And optic nerve sheet meningiomas can be tram track like this. They can be fusiform like this one. And sometimes they can have, other types of morphology, like they can be nodular, etc. We have also covered, please remember that many of the optic nerve meningiomas, 90% or within the orbit actually arise from outside the orbit. So from the optic nerve itself is only 10%. Most of them, they arise outside. We have done this case in our CNS. This is NF2, and we can see an meningioma which was suprasellar, and from there it is extending into the optic nerve. there is a lot of calcification. So you can see this calcification. And this patient, on contrast, has got bilateral acoustic schwannomas, meningiomas. This one is a optic nerve meningioma secondary to paracavernous meningioma. This is the definition of NF2, bilateral acoustic schwannoma, or first degree relative with NF2, with either of the two, and one of the definition is meningioma. So we have done all of this. So that's why I'm just skipping through it. On the other hand, candidate 3, look at this case. This is your case. Now, what is happening here? Can you describe it? This patient presented with proptosis, right eye. Over to you.
All right. These are selected images, coned down images of the sinus, and there appears to be expansion and sclerosis of the greater wing of the right greater wing of the sphenoid bone, and there appears to be of ground glass density, and I'm just looking to see if so. This would present hyperostosis, so this could be related to and plaque meningioma. So it's something that I would like to have a brain window to evaluate further.
I've given you with contrast, and these are fat saturated T1 weighted post contrast. Over to you.
Right. So on the MR images, on the post contrast fat sat MR images, there appear to be a high signal area, and there's just anterior to the right frontal lobe, and it shows a dural tail, and it appears to extend into the extraconal space. So I'm suspicious that this could represent a meningioma and plaque meningioma. My other differentiation.
So what happened? It is going into the orbit here. How did it go there?
Okay, it's going through the I believe the superior orbital fissure, and
can it go directly through the bone?
Yes, it's could. Intraosseous meningioma does that as well.
Here you are. Well done. Okay. So this is a very good case to understand, and these cases will come in the exam on a plain film. Please remember the behavior of some of the meningiomas, which what we call, they can extend into the bone. So the concept is they simply, the meningeal cells, they pass through the bone and come out on the other side. Simple as that. And if you see here, it has gone into the orbit. Now this is the medial rectus, and there is something sitting. If you look carefully, maybe there is a bit of enhancement within this diploid space. So you will be shown these kinds of scans on a plain X-ray initially, where there will be sclerosis. Whenever you find skull sclerosis, of course, you will ask for cross-sectional imaging, which will compare. There is a differential diagnosis to this, but always remember meningioma. So this tells you that what has happened. It has happened, it has gone from here into here, and this is a meningioma. Please remember that in orbit, as I told you, that 90% of the meningiomas come from outside. They are not from the nerve itself. Thank you very much, candidate 3. Thank you.
Thank you, Dr. Khan.
Okay, candidate 4. Sorry to keep you waiting. Now, we have got a T1, a T1, and this is a T2, and this is a T2. This is post-contrast, post-contrast. What is this? Candidate 4.
This could be a choroidal neoplasm. Since it's T1 bright, it could be a melanoma.
Excellent. So if you see here, there is a lesion here with a classical, what we call collar button appearance. And this, if you see here, this is on a T1 weighted sequence. It is high signal. And so collar button appearance, the innermost layer of the choroid is what we call the Brooks membrane. And if it passes through it, it will give you this kind of radiological appearance. Another key point is that it will be bright on T1 weighted sequence. And this is because of melanin. In your differential, which we have already done when we were doing our CNS, causes of high T1 signal. And one of them is melanin. Please remember that a tumor has to have high melanin content to be bright on T1. And many of the metastases, etc., of melanomas do not have enough melanin to be high signal on T1. But this appearance, where you have got this collar button appearance, is quite pathognomic, because otherwise you might confuse it with retinal hemorrhage and detachment, etc. Another case, and you can see this high signal with classical collar button appearance. 1 month old, what is your diagnosis, candidate 4?
Bilateral calcified lesions within the orbit, likely bilateral retinoblastomas.
Excellent. Whenever you find in under 3 years old babies or young children, if you find calcification, think retinoblastoma. It's critical. And retinoblastomas, there is a concept of unilateral, bilateral, and then trilateral and tetralateral. And the concept is that if you see, look at this one. This is the globe normal, and you can see that this retinoblastoma has then gone out. You remember retina, then there is choroid, then there is sclera, so it has gone through them, and it is gone out. And of course, it can travel through the optic nerve into the intracranial cavity. But there is a concept other than the bilateral that these tumors can be associated with a pineal tumor. Then we call it trilateral. And many a times there will be a tumor in the suprasellar region. Then we call it a tetralateral retinoblastoma. Whenever you find a retinoblastoma or a pineal tumor like this, trilateral or tetralateral, one of the leading questions in the exam, what will you do next? And please remember, the answer is that I will scan the whole of the neural axis with contrast, including the whole of the spine. Why? Because of the concept of drop metastasis. Drop metastasis, we have already covered it when we were doing CNS, that these are some tumors of the brain or vice versa, tumors of the spine or the cord, which extend or through the CSF spaces instead of hematogenous. So you have to do all of the imaging of the spine, and you will see these enhancing nodules, etc. Pineal tumor, germinoma, or pineoblastoma. So this is unilateral, bilateral, trilateral, or tetralateral. Another case where you can see that this is trilateral from STAT-DX, and you can see this tumor which is going through the sclera. This one is also, and it is going through the optic nerve, and there is a pineal tumor also. So this is from your Chapman, lesions involving the globe, and of course age of the patient, etc. That will be critical. When you are, please remember in CNS, whenever you see phacomatosis cases. This is a revision which I'm not going to cover because we have already covered it in CNS. Von Hippel-Lindau syndrome, tuberous sclerosis, NF1, NF2. All of these can have orbital manifestations. So in phacomatosis, always look at the orbit. This is a case of von Hippel-Lindau syndrome, and the definition is 2 or more than 2 hemangioblastomas. So for example, this one and this one. Look at the orbit, and there is a hemangioblastoma sitting there also. So always look at the orbit. In NF1, there can be optic nerve gliomas. In NF2, there can be optic nerve meningioma. And in tuberous sclerosis also, there can be orbital tumors. So always look into the orbit. This should be part of your protocol. Von Hippel-Lindau, of course, we have done when we were doing CNS. Okay, candidate 4. Look at this case. This is a CT scan, and what is happening? The patient is presented with 2 months old of variable diplopia. What is happening to the extraocular muscles?
There's bilateral thickening of extraocular muscles, sparing the tendinous insertion, suggestive of thyroid ophthalmopathy or vitopathy.
Excellent. Now, if you see here, all of these muscles, this is the inferior rectus, medial and the superior, inferior, medial, and the superior. Now, on this axial, look at the muscle belly. This is the belly. From here onwards is the tendon. So the tendon is not involved. The belly is involved, and these are thickened. And this is a bilateral finding. So that's the key. And so this is known as, most commonly, this is because of, we call it thyroid ophthalmopathy or thyroid associated orbitopathy. Various studies have given us various kinds of measurements of the muscle. But, just to keep it simple, but if you read about it, inferior rectus 6.2 and I think this is average, this is it. But usually people don't measure them, they just eyeball them. And so they will be thicker. Another thing is, go back to your pathology and make your radiology. That is the concept, right? So what happens in thyroid-associated orbitopathy, that there is lymphocyte infiltration which causes fibroblast-mediated glycosamine-glycan deposition, and there can be edema. And the involvement other than the muscle can be of the orbital fat as well as the lacrimal gland. So the orbital fat also is inflamed and enlarged. So that's why there is proptosis. So this is it. Sometimes you can get long cases. And you remember when we were doing our MSK, this is, bilateral symmetrical periosteal reaction in an adult, and you can see this finding. And they can give you with this, and the unifying diagnosis will be, this is a different case, by the way, that it is thyroid-associated orbitopathy. Candidate 4. Look at this muscle, look at this history. What comes to your mind? Describe it.
There is unilateral involvement of thickening of the medial rectus, which is involving the tendon insertion. And considering the history of pain, I am thinking of a diagnosis of pseudotumor.
Right. So, this is IgG4 related disease, and it is very important to understand IgG4 related disease. I think we have done in CNS also, correction in GIT also. So we know that it is a multi-system abnormality. So orbital pseudotumor is an old word. and it still continues. You can use it, but now people also use the word IgG4 related disease for this. Basically, it will be painful, and if you go give steroids, the symptoms will resolve. Please remember that there are various types. So muscles can be involved. We call it myocytic type. Globe can be involved. You remember, anything can be involved in orbital pseudotumor. So if muscles are involved, the key finding is that the tendons are also involved. And the pattern can be unilateral, it can be bilateral, lacrimal gland can be involved. There can be very infiltrative or invasive type. From the orbit, it can extend into the cranial cavity. And actually, it might look very aggressive and like a malignant tumor. So all of these things can happen. So remember it. And in this case, there is lacrimal gland involvement. So it will come in the differential diagnosis of globe lesions, in intraconal lesions, in extraconal lesions, and in conal lesions, as in muscular lesions. So every differential diagnosis will have that. This is a different case in which we can see the involvement of lacrimal gland, but this is not IgG4 related disease. Give me a differential diagnosis for a lesion in the lacrimal gland. That is the idea of this case. Candidate 4.
Pleomorphic adenoma and lymphoma. So
in head and neck, use the word lymphoproliferative disorder, and you cannot be wrong. The concept of lymphoproliferative disorder is that it is a spectrum of benign to malignant. So use that word in head and neck, particularly lymphoproliferative disorder. There is a differential diagnosis of extraconal lesions. Lacrimal is, of course, involved. And the three which I told you before also, you can always include them. One is lymphoproliferative disorder, which is lymphoma. Second is sarcoidosis, which can, and IgG4 related disease. These three, you cannot go wrong. And of course, there can be primary tumors, etc. So this particular case was actually a lymphoma. And so, the splenomegaly and lymphadenopathy was in the abdomen and pelvis was there. This, on the other hand, is a tumor, which is a mucoepidermoid tumor of, nobody can diagnose it. The main point is that we can only give the differential diagnosis. Okay, what is this lesion?
This is an intensely enhancing intraconal lesion. So it could be a cavernous hemangioma.
Okay, excellent. Now, the point is that cavernous hemangioma is the most common cause of a benign tumor of the orbit. Now, in your, so candidate 4, can you see my screen where I'm scrolling a CT scan?
Yes.
Okay, so just to give you, so cavernous hemangioma, if you see here, this is the type of case which will come in the exam. Please remember, it will be a brain scan like this. And your mind is totally focused on the brain. And you are going up and down and you are saying that CFS spaces are prominent and there is a chronic infarction here and whatever. But the finding is there, right? So this is what satisfaction of search is about. So I want to highlight that always look at the head and neck territory. Cavernous hemangioma is usually an incidentuloma. It is a vascular tumor, which is a benign tumor. Usually, the most common location is intraconal. There is a pseudocapsule. There is a concept of microcalcification, and that is why we can see it as high density. This is a non-enhanced CT scan as high density here. Of course, if you give contrast, it will enhance. And on MR, of course, it will be high signal on T1 and will enhance. So, but the key point I want you to remember is that always look for head and neck lesions in a brain scan. Candidate for last few cases are left. Can you see my screen with the 32-year-old female written on top?
Yes.
Okay, if you see here, this case is an interesting one, 32-year-old female with a history of swelling in left eye. And there is something here. And after 6 months, this enlarged, and this is the MR. Over to you. What is your diagnosis?
On CT, there are fat densities. On MRI, there is T1, which is suppressing on T1 fat saturated. So this could be a orbital angular dermoid.
Yeah, dermoid is a very important case, it's not very uncommon. It can be, at the medial canthus and usually at the lateral canthus also. Interestingly, dermoid has got a behavior where it can grow because of the concept of exfoliation. It will have multiple layers, and the key thing is that just like dermoids in the intracranial cavity, it will be fatty density on CT. And here, if you see here, this is a fat saturated sequence. Look at this focus, which is high signal on this sequence. It saturates here. And it can grow and it can burst open also. And if it will burst open, it will cause inflammation, just like in the intracranial cavity, where it will cause fat droplets and it will cause chemical meningitis. So this is a dermoid. And this is in your book, dermoid is also mentioned. So if you see here, dermoid and epidermoid, lesions arising from the orbital wall. So another case of dermoid, which is very small. This is a T1 weighted sequence. And then it will, this is a T1. And on fat saturated, this is a flare sequence. You can see that it saturates. So just to sarcoidosis, always remember. Please remember, sarcoidosis can cause anything in the orbit. Sarcoidosis, of course, has got a whole, spectrum of radiological features. It can globe intraconal compartment, conal compartment, extraconal compartment. This is a case of sarcoidosis with you can see bilateral lacrimal gland involvement with this kind of lobulated lymph adenopathy. So the point is, sarcoidosis, IgG4 related disease, and lymphoproliferative disorder, you can include anywhere in the differential diagnosis. This is the second last case of the day, and then will be the last case. Now, candidate 4. What is happening here?
There is a soft tissue density lesion in near the medial canthus of the right eye. There is no cortical destruction. There's no bony destruction. The bone is remodeled. So this could be a lymphoma.
Hint. It's an anatomy thing. This is an anatomy thing. Hint. If you see here, compare right and left. What is happening here? What is happening here? What is happening here? And what is this?
Naso-lacrimal duct is dilated, so this could be a decorous cystocele.
Excellent. So if you see here, look at the anatomy. Now, normal anatomy is that the lacrimal gland is on the lateral and superior part of the orbit. The lacrimal sac is in the medial canthus. From there, the nasolacrimal duct it originates, and the nasolacrimal duct, this is right and this is left, it goes and opens into the inferior meatus of the nasal cavity, which we will learn next time. And that is why when we cry, the tears come out of the nose, and that is why you have to use tissue paper, because the tears are going through the nasolacrimal duct into the inferior meatus and coming out of the nasal cavity. So in our case here, what has happened is that there is a nasolacrimal duct decorocystocele. So this is a very good case to learn anatomy. And you can see how it is dilating it. Look at this, 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 look at this. So there is an expansion, and there must be an obstruction, and that is why there is an expansion. And in your book, orbital extracornal lesion, look at this one. So this is an exam case, by the way. Decorocystocele, cystic mass, medial canthus plus enlarged nasolacrimal duct. And they can also show you with infection where it will enhance. So that is an important case for you to remember. Now, I told you that there is one case to left. After this, actually, this is the second last, so one more. Now, this case, I'll talk you through it. I have shown you in the CNS part, but just a repetition or revision, because it will again consolidate our anatomy. This case is post-operative, post-trauma, where extradural hematomas and things like that were drained. There were multiple fractures. Then the patient presented with a lot of congestion in the left orbit, and a CTA was performed, CT angiogram. This is axial CTA. So candidate 4, what is this structure? What is this structure? This structure, this vessel.
Superior ophthalmic vein.
Excellent. So the key thing is that it is superior to the level of the optic nerve. Now, on an arterial phase study, if you see here, this is the carotid artery and the carotid artery. It is a CTA study. There should not be any contrast in the superior ophthalmic vein. So candidate 4, what comes to your mind?
It could be dural arteriovenous fistula.
Excellent. If you see the coronal, now this also shows you the same thing. Actually, see the right and the left, right and the left. There is, look at these tortuous enhancing vessels inside. So there has to be a fistula. So this is a post-traumatic fistula, and this is another case. But just to make the point that what happens is that in this, an angiogram has been done from the right side. Contrast has gone through the anterior communicating artery to the other side. And when it went into the cavernous portion, it just blew off into the veins. So carotocavernous fistula is an exam case. And remember this. Okay, last case of the day. Now, this patient is a 51-year-old drug addict. She was horrible, and many infections, many things, very unwell. And she also had left eye redness with photophobia, headache, and vomiting. This is a PD weighted sequence. This is a T2 weighted sequence. Post-contrast, post-contrast. Describe the findings, please. This is the last case of the day.
So there is a loss of flow void in the left cavernous sinus. There is fullness of the left cavernous sinus with bulging of the walls. There is also preseptal thickening with optic nerve sheaths dilated and enhancement and thickening of the extraocular muscles. So this could represent a cavernous sinus thrombosis with congestion.
So what's happening to the orbit?
There's congestive changes due to
Congestive. Why will it enhance then if it's simple as that? Congestion.
yes. There is an adjacent spread of infection.
Infection. Okay, fine. Basically, in this case, what is happening is that if you see here, orbital lesions involving the globe, one of the thing is end ophthalmitis. There is a term end ophthalmitis. In end ophthalmitis, what happens is that there is infection of the vitreous and aqueous humor within the globe. But there is another term known as panophthalmitis. Pan means everything is on fire, everything is infected. This was a fungal, septicemia case. But the idea is to pick up what is happening. Now, if you see whole of this, it is enhancing. So this is the sclera, which is the outer membrane. Then the choroid, whole of the choroid is enhancing. It goes anteriorly also. And then there is myositis and muscles are enhancing. If you see the orbital fat, it is enhancing. And as you picked up very well, you picked up this thing very well, loss of normal signal void of the cavernous portion of the internal carotid artery. And when you see here, look at the cavernous sinus. So look at the cavernous sinus here, compare it with this, it is not enhancing, it is expanding. So what has happened is that this is a classical exam case. Panophthalmitis, and the infection has gone into the cavernous sinus of course, it goes through the venous system. And then there is sinus thrombosis. Because it was infective, what happens is then it will infect the wall of the carotid artery. And then there will be carotid artery thrombosis. So this is a classical exam case in which, because of infection, everything has gone. Even here, look here, thickening and enhancement of uvea sclera restrictive features of panophthalmitis, intraconal fat stranding, edema, enhancement of extraocular muscle, subcortical intraocular abscess. Look at this, cavernous sinus thrombosis, intracranial extension of infection. So that was the idea to show this case. This is a coronal, and on coronal you can see the same thing here, and you can see the filling defect on the post contrast. So thank you very much, candidate 4. Sorry, I think it was longish day, but having said that, I'm sure that at least the base of skull anatomy you will now remember, hopefully.